Hey guys, we are kind of picking up where we left off. We ended last time before all this started off, before all of our isolation and our classes got canceled. We ended off on the upper extremity. And so obviously now we're moving into the lower extremity. And so before we can talk about the hip, knee, ankle, foot, we have to talk about the pelvis and the pelvic girdle and kind of what are those structures, what are those mechanisms, what are those ligaments, what are those tendons, what are those muscles that kind of stabilize and use that pelvis as the foundation that it is. Just a side note before we get too far into this, we're going to talk about the updates to the schedule. We're going to talk about the updates to the practical procedures and all that stuff on our live lab on Monday morning. So I'm not going to get into the specifics now. We'll talk about that then. Also, another caveat is this is my first time really using this software. I've kind of dabbled and I've done a couple of tests, but I haven't. This is obviously, you're watching this. This is the first lecture that I'm doing with this software. And so while it is a recording video, obviously you see me. I cannot currently, in my format that I'm looking at my screen now, I can't see the video as it's being played right now. So what that means is I don't necessarily know kind of how far outside this pen goes before it gets outside the frame. So if I do something that's outside the frame, I'm sorry. It's just how it is. In my dry runs that I've done just before this, I have my whiteboard in here, and I'll move it over if I need to explain something a little bit more. And I have the table behind me, so if we need to, if I need to demonstrate anything, or if I feel like I need to demonstrate anything, I can hop back there. And I think that I've gotten everything within frame. So kind of without further ado, let's go ahead and dive into the pelvic girdle. All right. Perfect. All right, so structure and function. Pelvic girdle is made up of the sacrum, the coccyx, and then your two hip bones on either side. Okay, so if you put your two hands on your hips, those things that you feel, okay, those are going to be your iliums. Okay, those are, you have two on either side. Those hip bones are made up of your ilium, your ischium, and your pubis. Okay, so you've heard of, we've talked about, we've had you palpate your pubic symphysis before, kind of down in front, pretty low. Okay, that's where those two come in the front anteriorly, and then you have your two SI joints that we'll talk about kind of here in a couple slides, where those two hip bones or those two ischiums come together to form the sacrum. Your coccyx is your tailbone. Sometimes people fall and break it. I've heard it's a very painful thing to break, and our chiropractic friends will sometimes adjust it or manipulate it in order to relieve pain. We don't really do that on our end. I've heard of physical therapists adjusting or manipulating the coccyx. It's just not something that I've personally done in practice or that I've ever really been taught. Okay. Sometimes with pregnant women, they can sometimes have an issue with their coccyx. Again, not too familiar with that or anything like that. Okay, so the two joints that we're going to deal with, or the joints that we're going to deal with, we have our right and left SIs, or our sacroiliac joints. Those are going to be on the posterior side. You have your symphysis pubis anteriorly, and then on top where our pelvis kind of joins the rest of our axial skeleton, it's going to be your lumbosacral joint. Okay, so depending, there's some people out there that have an L6 vertebrae, and it really, or like an unfused S1. There really is kind of just a little bit of anomaly at that junction. So X-rays can be pretty helpful, especially with people who have kind of some chronic low back pain or anything like that, just to kind of be able to visualize what that junction is at the bottom of your lumbar vertebrae as it's joining up with your sacrum. So the pelvic girdle is also known as the pelvis. You've heard of your pelvis before. So it has lots of functions. Obviously, it's connected to the spine, so it's going to be important with that weight bearing or the supporting the weight of the body through our vertebral column. Okay, So VC in this is vertebral column. It passes forces from the body to the hip bones, and it also receives that ground reaction force that's created when your foot hits the ground, right? So we've talked, especially in those first couple of chapters up at the beginning of the semester, we talked about Newton's laws and how for every action there's an equal and opposite reaction. And when we start talking about the lower extremity, that's something that we're going to really drive home really hard, is that for every kind of force that your foot or your lower extremity pushes into the surface that it's standing on, there's going to be an equal and opposite force coming right up through the top of, or right up through that lower extremity. And then it's going to go up to the pelvis and get translated up through the spine. So it's kind of one of the treatment principles that we're going to talk about here at the end, is having that stability or having that foundation kind of around the pelvis. Okay. We'll talk about it in 140 here in a couple weeks as well, about kind of the posterior chain. You're going to hear me talk about the posterior chain kind of until you're blue in the face. And I do that on purpose because it is so important. But creating that posterior chain, that strong posterior chain, creating that foundation to allow that ground reaction force to be kind of dissipated and handled correctly from our musculature as our foot hits the ground. Okay? Supports and protects the pelvis vertebrae, or the pelvic, not vertebrae, the pelvic viscera. So there's a lot of organs, there's a lot of things happening kind of down lower in your abdomen that need to be protected. And it's going to provide attachment for muscles. Like we just talked about, those muscles are key to help dissipate that ground reaction force. And then there's that bony portion of the birth canal in females. And in a couple slides, you're going to see the big differences that that we find in the male pelvis versus the female pelvis. One of those main reasons is for childbearing. Okay? Guys, we don't have to worry about that. Females, it is a big thing that happens, and it's there's a lot that goes into it, and there's the pelvis is created in a way to allow that process to be a little bit better, obviously. Okay. And then with walking, there's lots of pelvic motions in all three planes that happens with walking, and we'll talk about that at the kind of more towards the end of the lecture. So these are our three joints. We've talked about them already. You have your pubic symphysis there in the front. You have your two SI joints, your right and your left, posterior laterally, and then superior you have that lumbosacral up at the top. Okay. So we have a false pelvis and we have a true pelvis. So that false pelvis is between the two iliac crests. So if you put your hands on your hips, and you really feel kind of that iliac crest, okay, that area between those 2 points are going to be your false pelvis. Okay? It's going to be superior to the pelvic inlet, and it doesn't house any pelvic organs. The things that are in that area already are like your bladder and your small and large intestines and all those things. Okay, so we haven't really gotten quite into the pelvis or the true pelvis, so we don't really have any of those pelvic organs yet. Okay? That pelvic inlet that you'll see on the next slide, illustrated on the next slide, is a little bit easier to see. That's seen by drawing a line between the sacral promontory posteriorly and the superior border of the symphysis pubis anteriorly. Okay? Sometimes women will have this kind of measured, and not really getting too far into those things because that's way outside our scope. It may be part of a pelvic exam that females get. And then below that, you have your true pelvis that lies between the pelvic inlet and the pelvic outlet. Okay, and that is kind of also where the birth canal is. All right, so pelvic outlet, so drawing a line from the tip of the coccyx to the inferior surface of the pubic symphysis. And then you have your true pelvis, is also known as your pelvic cavity. And these all contain portions of the GI tract, urinary tract, and some of the reproductive organs. And also, like the forms the birth canal, like we just talked about. Okay, so this is the illustration. So everything on top or superior to that pelvic inlet is going to be your false pelvis or false pelvis. The area between your pelvic inlet and your pelvic outlet is going to be your true pelvis. Okay. So another good just representation. This is for kind of a superior anterior view, illustrating where the false pelvis is in pink, and then the true pelvis in the blue fashion. All right, so let's talk about male versus female. So with males, it's going to be the superior opening is going to be heart-shaped, and then the pelvic cavity is longer and more funnel-shaped. Okay, so it's going to be more compact. It's going to be more. More compact. So the two sides are not going to be as wide. And when we start talking about the biomechanics, that's where this will really kind of come to fruition, especially when we start talking about the biomechanics. Walls are more vertical, the sacrum is longer and more curved, the acetabulum and ischial tuberosities are closer together. Okay, so if we go back to our lever arms, okay, I want you to start thinking about kind of the width of your pelvis as creating either a larger or a smaller torque arm or lever arm. Okay, so we know that the longer the lever, okay, the more force is created. The shorter the lever, the less force is created. Okay, so with males having a narrower, kind of taller pelvis, we have a smaller, or they have a smaller torque arm. This is really kind of challenging to do without being in front of you guys. Okay, but the female pelvis is going to be obviously, or not obviously, but it's going to be more oval in the superior opening, and it's going to be shorter and less curved. Walls are not as vertical, and the acetabulum and ischial tuberosities are farther apart. So in essence, the female pelvis is creating a longer lever arm. Okay? So I'm going to draw something, and I hope that it goes well. Okay. All right. I want to say I'm still in frame. I don't quite know. Okay. So if this is my male, male, female, okay, and then my male pelvis is going to be there. Okay. That's typically when I draw pelvises. They're drawn as triangles usually when I do it. Okay. The female pelvis is going to be wider and not so tall. Okay. So if my hips, okay, if they rotate around an axis in the frontal plane, we're going to say it rotates there. Okay. So as you can see, that lever arm is significantly shorter than that lever arm there. Okay. So if I throw in some legs, okay, again, I'm hoping that this shows up and it's in frame, because if not, that will be sad. Okay. And then we have our ground reaction force coming up the legs, okay, at this rotation point. Which one's going to have the greater amount of rotational force? Okay? Because that's in the frontal plane, that's the pelvic motion that we're looking at. Okay? So the female with the wider pelvis, the greater, longer torque arm, okay, they're going to have a greater rotationary force than the male pelvis will. Okay? And this is where you start talking about the terrible triad with knees. Okay? Because with that rotationary force, it's going to create a valgus moment in the knee. Okay? And loaded valgus moment, as we've talked about before, are not helpful. Okay, they don't do good things to the ligaments in the knee. They don't do good things to the meniscus, and they lead to greater injury. Okay, so we'll talk about that more come lab time, but I don't want to say and draw really anymore because I don't want to confuse people. All right. So in the pelvic arch is wider and more rounded, as with the male's pelvis, the pelvic arch is narrow and less rounded. Okay. So up top, you see the pelvic arch of the male, and then the pelvic arch of the female is going to be wider and less deep. Okay. So if you have any questions about that, or you have questions about what I draw, write them down on your notepad, and then we'll talk about them on our live kind of webinar lab session on Monday morning. All right, so moving on, we have our SI joint. It is a synovial joint, however, it is non-axial. In the joint between, it's the joint between the sacrum and the ilium. It's known as a plane joint, although it's not like two pieces of paper that slide on each other. This is a very irregular articular surface, and it kind of locks the two surfaces together, and people can kind of think about it as like a locking key. Okay, not everybody's articular surfaces are the exact same. They kind of form during bony development, and so it really is like a locking key. The two surfaces fit together very congruently, and as we'll talk about in a minute, there's just not a ton of motion. Okay? And with the sacroiliac joint, if we go back, and you see kind of the shape of the sacrum, you've heard me use this term before in class of a keystone. Okay? And I believe I asked if there was any masons in class. But the keystone, if you ever look at like a masonry brick archway or a stone archway, that stone up at the top is always going to be referred to as the keystone. And it has two angled sides, and it keeps the two sides from kind of collapsing in on each other. Okay, that's what the sacrum is. That's what the SI helps to stabilize. Okay? So the function of it is to transmit weight from the upper body through the vertebral columns and into the hip bones. Okay? There's a ton of stability in this. There's very little mobility. Okay, and it's kind of a hot topic within the profession is how much. I think probably between our profession and kind of the orthopedists is because it's very hard to measure how much motion is there as well. Because there's not a lot and there's all types of, and it's really deep, it's really hard to kind of physically measure how much motion there truly is. I've heard of people's proposals of kind of going in and implanting kind of little metallic identifiers and then doing kind of like a functional MRI or a functional fluoroscopy, like a continuous x-ray, and really kind of being able to physically measure. However, getting that past the IRB board would be really challenging. So obviously, to my knowledge, that hasn't happened. If when you're doing your presentations or your literature review and you're like, man, SI, I want to study the SI, I'm going to look up and see how much motion is going to be at the SI. That would be a great thing for you to look at. Okay. It's lined with hyaline cartilage, and then there's a synovial membrane lies the non-articular portions of the joint. Okay. There is a capsule, and it is reinforced by ligaments. Okay. So as you'll see in the next coming slides, it's a very kind of hodgepodge of stability. There are so many things that stabilize the SI joint. For some people, it's kind of hard to understand that how is there any type of motion going on at the SI joint, okay? Because as you'll see, there's so many ligaments, and there's so many muscles that will help stabilize. That's kind of when we have that kind of low lateral back pain. That's kind of the first things that we look at is what's the function of the SI, what's the alignment of the SI. Okay, but it is a fibrous capsule that is reinforced by ligaments, and it usually is very stable. Okay? Unless there's a trauma or some type of injury or pregnancy during the hormone releases, you start having a lot of instability at that SI joint, which can lead to some issues. So that's where the SI joint is going to be, that joint between the ilium and the sacrum. So first, let's talk about some SI joint motion. And these are, by all means, not all of them. If you go to a continuing ed course on SI mechanics or SI treatment or even low back pain, and they talk about SI, they're going to talk about terms that we probably won't cover today, like an upslip or a hypomobile a hypomobile SI segment, or you'll hear the word stuck, like a stuck SI. You'll hear the words downslip. You'll hear about a rotated innominate. Okay. Well, these are things that we'll probably talk about in lab, but we're not going to really kind of focus on. In 160 next fall for you guys, we do have Sarah, who's a physical therapist at Carolina East in Women's Health. She does come in and she starts talking about rotation kind of within that arena. So this is kind of just a good foundation. Okay. So with nutation is just sacral flexion. It's not talking about pelvic flexion. It is just talking about the sacrum itself, how it can move from kind of a more neutral position into a flex position. Okay? Where the base of the sacrum moves anteriorly and inferiorly. Okay? And remember, base of the sacrum, it does not mean the coccyx, it means the upper portion. So where that lumbosacral junction is, okay, that's going to be the base, that's the superior end, and that moves anteriorly. And the inferior of the sacrum and coccyx moves more posteriorly. Okay? On the opposite of that is counter nutation. Okay? Counter nutation is the exact opposite of nutation or sacral extension, okay? Where the base or the top moves posteriorly and the tips move anteriorly. Okay? There is minimal nutation and counter nutation that occurs. It usually only occurs with other joint motion, such as lumbar extension and flexion. Okay. So with nutation, you have trunk flexion, where your not spinous processes, but your lumbar spine goes into flexion. Okay, that's going to bring the sacrum with it, and hip extension will also pull it into nutation. Okay. Counter nutation is with trunk extension and hip flexion. So it's going to be, if you go into hip trunk extension, remember, this is trunk extension, not lumbar flexion. Okay, so let's draw it. Ooh, no, there. Okay, so we don't need to draw it because it's here. Trunk flexion, okay, remember, that's just all of our spinous or all of our vertebrae going into a flexed position. Okay, that's not just saying your lumbar spine. Okay, if we were talking about lumbar spine and we went into extension, that would cause a nutation at our sacral, kind of a nutation moment for our sacrum. Okay? But if we're just talking about trunk flexion, and I don't think our book does a very good job of illustrating these things. Okay? But if we're going into trunk extension, you can see how that is rotating that sacrum posteriorly, creating a counter nutation. Okay? But if we were just looking at our lumbar spine and we did a flexion moment in an upright position, if we went into lumbar flexion, then that would be a counter nutation. Okay? So terms make a big difference when we start talking about these things. Is the whole trunk going into flexion or extension, or is it just the lumbar spine? Okay? And again, If you have questions, please write them down so that way when we meet in the live format, you can ask them and we can act it out and we can talk about it a little bit more. Okay. So our sacrum is wedged shaped. As you can see, we talked about a few minutes ago, talked about the keystone structure of it. Kind of looks more like a trapezoid, I think, than like a wedge, or like a true wedge. Okay. It is made up of 5 fused sacral vertebrae. It's located between the 2 hip bones, obviously, and at the posterior border of the bony pelvis, and it's the anterior surface is concave. Okay, so that anterior surface, if this is anterior, this is posterior, the anterior surface is concave, posterior surface is convex. That's not really truly all that important for you to know. Okay. And then your ilium is your superior portion of our hip bone. That's what creates that SI joint. All right, so the more sacral landmarks, we have our base. That is the superior surface of S1. It articulates with usually L5, although some people may have an L6. The promontory is the ridge projecting along the anterior edge of the body of S1. We cannot palpate that. The superior articular process is located posterior on the base, and those articulate with the inferior articular processes of L5. Okay, we're going to talk about a ligament that crosses that gap here in a little bit. Okay. The alas are the lateral flared wings. Those are kind of like our fused transverse processes on our sacrum. We have 4 foramina located on our sacrum. This is located on the anterior and dorsal, or anterior and posterior surfaces. These are the exits for the anterior and posterior divisions of our sacral nerves, our sacral spinal nerves. Okay, if we looked at them, once we get back to our classroom, the anterior foramina are more larger. Obviously, again, we can't feel these things. That's not going to be on the anterior surface. Okay? The articular surface is similar to the auricular surface. Similar to the external ear. It's located on the lateral surface of the sacrum, and it articulates with the ilium. Okay? It's a regular surface that assists in locking the 2 surfaces together. Again, it provides that great amount of stability and a very kind of minute amount of mobility. Okay? The pelvic surface is concave. It has a concave anterior surface. Okay? I'm trying to see if there's so this shows it a little bit how kind of irregular that articular kind of surface is. So our ilium, remember those are our 2 kind of bones that connect into either side of our sacrum. So we have our tuberosity as our large roughened area between the posterior portion of the iliac crest and the auricular surface. It's our attachment for our interosseous ligament. Also, we're going to talk about our PSIS here in a little bit, and that tuberosity is part of that. You have your auricular surface. It's an ear-like shape. So on this slide, this auricular surface, similar to the external ear, this is the shape. It's not the structure, or like doesn't feel like your earlobe. It's not soft. It's not squishy. It's shaped like your ear. Sorry if that wasn't confusing before. Located inferior and anterior to the iliac tuberosity, and then your iliac crest are going to be those superior ridges of that you can feel kind of as you push down. Okay. We have our posterior superior iliac spine. Okay. You have your posterior inferior iliac spine. You have your greater sciatic notch. Okay. So our PSIS, those are going to be kind of the dimples that you can feel kind of on your back. We'll palpate them here in lab in a couple of days. Okay, that's going to be that posterior projection of the iliac crest. It's going to be a big attachment for our posterior sacral iliac ligaments. Again, When we talked about the TMJ, we had a bunch of ligaments that were really named for where they went, and that's the same thing um, in this region. Is that you're gonna see a lot of ligaments here in a couple slides, and you're gonna get worried and freaked out and be like, "Oh my gosh, how am I gonna remember those?" A lot of those things are gonna be named for where they go, and they pretty much do the same thing. It's just to stabilize the SI joint. Okay. Your posterior iliac, inferior iliac spine, your PIIS, that lies inferior to the PSIS, and it's going to be our attachment for our sacrotuberous ligament. Okay. You have your greater sciatic notch that is formed by the ilium superior and ilium and ischium inferior. You have your greater sciatic foramen, that's the formed from the greater sciatic notch by ligamentous attachment. And then you also have the sacrotuberous ligament posterior, you'll see it in a minute, and the sacrospinous ligament inferior border, and the sciatic nerve passes through that. Okay, so you have a kind of a ligament that goes from here to here. And it's gonna yeah, that's gonna be from here to here, and that's a big key term for where that the sciatic nerve. Okay, that sciatic nerve is about the size of a nickel. Again, I don't want to tell you this. We're gonna be really hard fast to go to the ECU anatomy lab because ECU is closed. It may be something that we attempt to do later on in the summer, okay, when things kind of get back to normal. But as of right now, the ECU anatomy lab is a no-go. Right. So our ischial landmarks, still going on our ischiums here. Our body is our ischium superior to the tuberosity, and then we have our lesser sciatic notch. That's going to be that smaller concavity that's going to be inferior to our greater sciatic notch. Okay. We have the spine located on the posterior body between the greater sciatic and lesser sciatic notches. Again, this is going to be all more clear. Okay. You have your tuberosity, which is the blunt, rough projection on the inferior aspect of the body. It's a weight-bearing surface when sitting. So these are your ischiotuberosities. This is what attaches for the hamstrings as we get into our hamstrings and our muscular surfaces. This is what you sit. These are your sit bones. Okay, so if you don't have a lot of meat back there, you can't, and you have a hard time sitting on like metal bleachers when you go to a sporting game. This is kind of what usually starts hurting when you start sitting on rough surfaces. Okay. So these are this up here is your ilium. This down here is your ischium. And then you also have your pubis out front. Okay. So remember, our hip bones are a fusing of 3 bones. Your ilium that we just talked about. And then we have our ischium, okay, with your ischial spine, your lesser sciatic notch, the body of your ischial ramus on the inferior aspect, and then that ischial tuberosity. Okay. I believe we've had you guys palpate each other's ischial tuberosities before. All right. So this is where we start coming into our ligaments. Kind of a big list. Don't get freaked out. They're usually named for where they go. Okay, so your anterior sacroiliac ligaments runs from your sacrum to your ilium on the anterior surface. Okay, we're going to go through these as we go. Again, you can see how this is on the anterior surface, right? Your anterior sacroiliac ligament. Okay, big not weight-bearing structure, but big supporting surface, and you can see already how kind of stabilized that SI is. And as we go further and we look on the posterior side, you'll see it a little bit more. Okay? So that anterior sacroiliac ligament is huge. It's flat ligament on the anterior surface, connects the ala and pelvic surface of the sacrum to the auricular surface of the ilium, and it holds together that anterior portion of the joint. Again, this is an anterior view, and you have that anterior sacroiliac ligament Then we have our interosseous sacroiliac ligament. This is the deepest, shortest, strongest sacroiliac ligament. It fills the roughened area immediately above and behind the auricular surface, and the anterior sacroiliac ligament connects the tuberosities of the ilium and the sacrum. Okay, so that's going to be up at the top. It's going to be strong. It's going to keep those two surfaces together. Okay? So as you're seeing this, imagine all the forces that are going through your SI joint, especially like if you jump on a trampoline or you even just jump off a curb, right? You have those ground reaction forces coming up through your legs, and those forces are going to be transmitted right through those SI joints. And so we need these ligaments to be nice and strong to keep those two surfaces. So then we have our short posterior sacroiliac ligament. This runs obliquely between the ilium and upper portions of the sacrum on the dorsal surface, and this prevents forward movement of the sacrum. Okay. Forward movement. So this is a posterior view. Again, notice how much ligamentous stability we have. Okay. Kind of this whole thing is going to be our short posterior sacroiliac ligament, and it's going to keep that sacrum from moving anterior on our ilium. Okay. We have our long posterior sacroiliac ligament, which runs vertically between PSIS and lower portion of the sacrum, and this prevents downward movement of the sacrum. Okay. So look at the direction of the fibers. So our long posterior sacroiliac ligament attaches superiorly on our ilium, inferiorly on our sacrum, and that prevents our sacrum from going down. Okay? You could also look at it this way, that if someone has an upslip or their innominate or their hip bone gets slid upwards, it's going to stress that long posterior sacroiliac. Now we have our sacrotuberous ligament. This is again very strong, triangular shaped, runs between the PSIS and PIIS of the ilium, and from the posterior and lateral side of the sacrum inferior to the auricular surface, and from the coccyx to the attach on the ischiotuberosity. Okay. This is one of the key insertions or attachments for the gluteus maximus. Okay. And this prevents forward rotation of again, big shaped, big fan shaped. Okay. Creates a lot of stability. We have our sacrospinous ligaments. This is triangular shaped, lies deep to the sacrotuberous ligaments, and is a broad attachment from the lower lateral sacrum and coccyx on the posterior side, and it attaches all the way over to the spine of the ischium. Okay. That's going to be that sacrospinous ligament. Again, or not again, but this isn't going to create a lot of stability because it's kind of thin, narrow, and it traces a long way to get where it's going. Then we have our iliolumbar ligament. This connects the transverse processes of L5 to the ala of the sacrum. And then we'll cover this a little bit more in our lumbosacral joint. Sorry if there's questions. Like I said, if you have questions or if you find that you're not understanding things too well, be sure to kind of write them down in the present. We've been going for about 38 minutes or so now. I just don't want you to get to the end of this and be like, oh yeah, I had a question. Now where was that question? Okay. So our pubic symphysis is anterior, located in the midline of the body. We have had you guys palpate this on each other before. Remember that if you do palpate this on your patients, you go from a top down. Do not go from the bottom up. That would be a no-no. Okay. Right and left pubic bones are joined anteriorly to form the pubic symphysis. There's a fibrocartilaginous disc that lies between the two bones. This is characterized as an amphiarthrodial joint with little movement, and that's kind of, you can put an asterisk there as well. Okay, because especially if you have a female patient who is having a lot of, either in the first trimester, I want to say between weeks 6 and 12, there's a burst of relaxin, and then during the third trimester, there's another kind of more constant release of the hormone relaxin, and it makes everything, especially in the pelvic girdle, kind of loosey goosey, and it helps. The purpose of it is to help with childbirth, but it can really throw some people off. We have my wife had some issues with her pubic symphysis separating with Marshall, our second born, and it took her a while to get back to it. Okay, where the pubic symphysis then separates, and then every time you walk, it kind of just glides on each other. And again, we'll talk about this more in lab. So our ligaments, there's not too many. We have our superior pubic ligament and our inferior pubic ligament. The superior attaches to pubic tubercles on each side of the body, and it strengthens the superior. No kidding. Okay, superior and anterior portions of the joint. The inferior pubic ligament strengthens the inferior portion of the joint. Pretty much named for where it goes. Okay, so our pubis, we have our body, we have our superior ramus, our inferior ramus, and our tubercle. Okay, so our body is the main portion, and then our superior ramus is the superior projection. The inferior is the inferior projection. And our tubercle projects anterior on the superior ramus, and it's an attachment for our superior pubic ligament. Okay, so there's our pubic symphysis with our fibrocartilaginous disc. You have your inferior pubic ligament, your superior pubic ligament. You have your superior pubic rami, your inferior pubic rami. And then we didn't really talk about this yet, but your inguinal ligament. Okay, that little area underneath there. If you've had anybody, usually a male, if they've had an inguinal hernia, okay, there's a little hole right in there for the vas deferens to go through. And if that hole gets too big, you can have little bits of your small intestine kind of poke through and have what's called an inguinal hernia. So this lumbosacral joint structure and ligaments. The structure is your fifth lumbar vertebrae and first sacral vertebrae. And the bodies are separated by an intervertebral disc. Okay, held together by anterior and posterior longitudinal ligaments that we've talked about first. Normally, at this point, I would ask you a question of what is the characteristics of the anterior ligament down in the lumbar spine, and hopefully you would say, that the anterior longitudinal ligament is wider at the inferior segment down in the lumbar spine, where the posterior longitudinal ligament is more thin. And what does that open us up for? More in the lumbar spine, more so than in the thoracic spine, and it's going to be that ruptured disc because it's not supported on the posterior side of the body with that posterior longitudinal ligament. Okay, we've talked about that. The ligaments, use your iliolumbar ligament and then your lumbosacral ligament as well. Okay, so your iliolumbar ligament attaches on the transverse processes of L5, and then they run laterally to the inner lip of the posterior portion of the iliac crest. This limits rotation of L5 on S1. Circle it, star it. It helps to limit and provide stability of L5 on S1. It assists in the articular processes and preventing L5 from moving anteriorly on S1. So if you talk about what segments usually result in a posterior disc lesion, it's going to be L4, L5, not L5 on S1, because L5 on S1 has the use of this iliolumbar ligament to help stabilize it. You also have your lumbosacral ligament, again, attaches to the transverse process of L5, and it runs inferior and laterally to attach on the ala of the sacrum, and the fibers intermingle with the anterior sacroiliac ligament, okay? And again, provides lots of stability for L5 on S1. So our lumbosacral angle is determined by drawing one line parallel to the ground and another line along the base of the sacrum. The angle will increase as the pelvis tilts anteriorly, and that angle will decrease as the pelvis tilts posteriorly. We'll see it in just a second. Okay? Drawing a line parallel to the ground and a long line along the base of the sacrum. Okay? Our optimum angle, okay, you could also kind of right out to the side over here. Neutral pelvis is roughly going to be 30 degrees. Now, it has to be 30 degrees because that normal extension or the normal lumbar lordosis is going to be creating that 30 degrees. Okay? The greater amount of lumbar lordosis, okay, the greater amount of angle for our lumbosacral angle. Okay? And what is key is going to be that shearing stress. Let's see. Is there a picture? Aha, great news. Okay, the less lumbar lordosis, the more flat back you have, is the more decrease. Okay, you're gonna have a decrease in that angle, and you're gonna get more force, more ground reaction force going up through your vertebral column. Okay, so this is normal. You can see that the angle is the kind of the tilt of the base of the sacrum. Okay. So as we have that increased lordosis, okay, I'm going to refer back to my stereotypical patient that does this is going to be your adolescent female who kind of pushes their butt out and kind of sticks their belly out, and you can see how much more. Not only does that cause an issue here, okay, it also causes a big issue kind of further up the spine. Okay, it's kind of like the personal trainers in the room will kind of understand or appreciate the use of I think in the personal training world is the kinetic chain. No, we use that in ours. Kinetic train or anatomy train or something along those lines. Okay, that change within that lumbar lordosis is number one going to cause kind of a sway back posture. Okay, number two, it's going to create a lot more shearing force here. Oh, pardon. Okay, you're also going to have, with a decreased angle, you're going to see a lot more flattening of that vertebral column. Okay, so less lumbar lordosis, decreased angle, but it's also going to create a lot straighter vertebral column. And again, think of the ground reaction force coming straight up the legs. Okay, and instead of kind of the spring-like action of a normal neutral spine, kind of dissipate some of that force is going to go straight up, and it's going to create kind of bony changes and issues. Okay, so pelvic girdle motions. You've heard me talk about nutation and counter nutation. Those are going to be sacral motions. This is going to be more pelvic girdle motions, so kind of whole motions of the whole pelvis. Okay? As we've talked about before, it happens in all three planes. Okay, so with our sagittal plane, remember our sagittal plane is anterior posterior. Okay, with the AS and pubic symphysis should be in the same vertical plane. Our anterior tilt, okay, where the pelvis tilts forward, on ASIS, anterior to the pubic symphysis. Okay, and we're gonna again. I know that this can be kind of confusing because we're doing it in this format, but that posterior tilt is going to be when the pelvis tilts backwards, and it's going to create the ASIS posterior to the pubic symphysis. Okay, and we'll talk about this more in lab, and if I don't talk about it, remind me and we'll go through it a little bit more. Okay. But our neutral spine, where your ASIS and your pubic symphysis are in the same plane. Very helpful. Good things. You can see that there's a normal amount of curvature within the spine. Okay, that lumbosacral angle is normal, so there's not a ton of shearing forces that's going to create spondylolisthesis, a Scotty dog, and a fracture of spinal cord injury. Okay. if we have an anterior tilt, again, going back to my stereotypical adolescent female patient, okay? Now, when the spine is in this much curvature, number one, you're increasing that shear force, right? You're going to have them come in and be like, oh my gosh, my low back hurts. Well, no kidding. Look at all the shearing force that you're having as you're trying to complete your gymnastics routine, right? Then you start looking up at how much curvature you have, and then we start talking about our length-tension relationships in our muscles. See, it's all connected. It all goes around. You didn't think it was going to happen this time, but it did. Okay? So that length-tension relationship of those muscles are now all going to be out of whack. And as that kind of area gets loaded with our ground reaction force coming up from the forces coming up from the ground, okay, our muscles that all kind of connect to all these sacral or these vertebral segments aren't going to be able to dissipate that force as well as it is in this picture. Okay, that posterior pelvic tilt. Okay, again, we're flattening the spine, decreasing the amount of lumbosacral angle that there is, and increasing the effects of that ground reaction force coming straight up the spinal column. Excuse me. In the frontal plane, we have our lateral tilt. Okay, so in our frontal plane, the iliac crest should be level. So if I'm coming at a patient and I'm looking at their, and I'm putting my hands on their two iliac crests, they should be level. Okay. Lateral tilt occurs when two iliac crests are not level, where one side moves up while the other side moves down. Okay. So the point of reference, meaning which side is moving. We're going to look at the side that is unsupported. Are you walking? Walking is just a series of single leg stance. Okay. With that, we also will see some pelvic rotation, which occurs in the transverse plane around a vertical axis, where one side of the pelvis moves forward, backward in relation to the other side. Again, we are going to use the unsupported side, okay, as the point of reference. And then our ASIS is going to be landmarks when looking down at the patient. Let's take a look. Okay. So as we are walking, okay, this is going to be our stance foot. This is going to rotate forward. So we're going to kind of rotate around that axis. Okay. That's going to be an anterior rotation, okay, anterior rotation, and a posterior rotation. Okay. I don't particularly like how they did this slide because this would be terminal stance and this would be kind of early stance. So as I'll get up and show you. Oi. Okay, so in this picture, as I take a step with my left leg, okay, I am in right posterior pelvic rotation. Okay, and as I advance my unsupported leg, I'm going to be in right anterior rotated pelvic position. Okay. So in my opinion, B and C are backwards. It makes it a little bit confusing to understand. Okay. So really you are going into internal and external rotation on the supported side. Okay. So when you have that anterior, okay, anterior pelvic right anterior pelvic rotation, you have a left internal rotation moment. You see it? Okay. When you have a right posterior pelvic rotation, you have an external rotation moment in your left hip, or a contralateral external rotation. Okay. So with a right anterior pelvic rotation, you have a contralateral internal rotation. With a right posterior pelvic rotation, you have a contralateral external rotation. Okay. Again, if you have questions or you need clarification, please ask us in lab. Okay. This is going to be something that will be easy for us to show you in lab. Okay. All right. Then we're going to talk about lateral tilt. Okay. So you have, usually we want our, if we're in neutral spine, okay, we want our two ASISs to be right in line with each other. We want them to be right in the same. Okay. Now, when we walk, okay, we have a normal amount of what we call hip drop, okay, where that unsupported leg, okay, kind of drops down a little bit. Okay. Drops down a little bit. Okay. Now, when it becomes excessive, then we have what's called a Trendelenburg gait, when that pelvis drops down. Okay. That's going to be excessive, kind of excessive lateral tilt is going to be called Trendelenburg gait. We'll talk about that more when we get into our gait section. Okay. Now we're going to talk about muscular control and what types of muscles control all of these pelvic motions. Okay. There's a lot of force couples, okay, that move and control the pelvis. Okay. So anterior, we have our lumbar trunk extensors, or our rectus spinae, that pull up posterior. Okay? And then our hip flexors that pull down anterior. Let's go to the next slide. Okay, so by anterior, okay, we mean an anterior pelvic tilt. So on your notes, write anterior pelvic tilt to make it a little bit more clear. Okay? So to achieve that, okay, we're going to create an anterior pelvic tilt. Okay, our trunk extensors are going to pull up, and our hip flexors in a closed kinetic chain are going to pull down. Those two force couples, okay, are going to create that hip bone, or the innominate, or the ilium, anterior tilting. Okay. On the posterior tilting, okay, we have our abdominals that pull up anteriorly, and then our gluteus maximus and hamstrings that pull down posteriorly. Okay. When we start getting into treatments in 140, we'll start talking about why it is so important to have a stable abdominal muscles in our hip, in our hamstrings, and our gluteus maximus, our hip extensors, our hamstrings, and our gluteus maximus. Okay? Because those are going to be things that are going to help stabilize what's going on. Okay? Especially, so I'm going to ask a question here, and I'll wait a second before I answer so that you can kind of think about it. Which of these two muscle groups, okay, these or these, are we going to strengthen in somebody, kind of that stereotypical adolescent female who resides or rests in an anterior tilt? Okay? Are we going to strengthen these muscles, or are we going to strengthen these muscles? Okay, because we're trying to get them out of that position, because that position is dangerous. We've talked about that and why that position is dangerous. Okay? If your answer was these muscles over here, you would be correct. Okay? So that adolescent female who comes in and she's complaining of severe low back pain, we would normally be strengthening these muscle groups. Okay? We're going to strengthen these muscle groups, and guess what muscles we're going to stretch? We are going to stretch these muscles, because these muscles are going to be the tight muscles. Okay? Hope that makes sense. Trying to think of where we would strengthen those muscles. But if they're in posterior tilt, you're not going to see people in posterior tilt. Just doesn't happen. All right. And then with our lateral tilting, where our lateral trunk benders, okay, so our rectus spinae and quadratus lumborum pull up on the unsupported side, and our hip abductors, our gluteus medius and minimus, pull down on the supported side. Now you could also read that on the contralateral and on the ipsilateral stance side. Okay? So if this is our stance leg, the leg that's in contact with the ground, okay, you have an ipsilateral hip abductor with our glute min, glute med, and our contralateral QL, erector spinae contraction. That's going to help stabilize that pelvis from excessive lateral rotation. Okay. All right, so that's just a good table if you're a table person, to understand kind of what motions happen at the anterior girdle, what motions happen at the vertebral column, and then what happens at the hip during those activities. Okay? Again, if you have questions or if you've gone through this and you're like, Dr. Friedlander, you have completely spaced me out. It's been an hour. I don't want to look at you. I don't want to hear your annoying voice. That's fine. But please, please, please write down some questions and make sure that you ask me about them on Monday morning. Okay? I'm going to send out an email here in a little bit, kind of talking about what to expect on Monday, what time we're going to start, and all of that fun stuff. Okay? So I will talk to you guys on Monday. Thank you.